them now. Maybe not intubation, but I went a little haywire there. But starting IVs, why would we not want to start why would we want to start IVs? Bleeding afterwards. So once that TPA starts, or TNK, TAPK is what we use now, but for your purposes and purposes, it's TPA. But the increased bleeding, we're not going to go and do a lot of sticks. So when we start TPA, we want 2 IVs in that arm, wherever. But because we don't want to go, we're going to handle that patient with kid gloves afterwards because they're going to be at risk for bleeding, and we don't want to produce any more trauma because of it. We don't want them bleeding out. Oh, I meant to do something. All right, lab assessment. We're looking at PT, PTT, INR, and your hemoglobin. So those specific. Why do we care about PT, PTT, and INR? Bleeding. What if they're too high? Are we going to start TPA? No, because we're just going to make more symptoms. We're going to make more problems. Does that sound right? We're going to create more problems. Okay. So yeah, we're checking to make sure if maybe they already have a bleeding issue. So we want to check those before we give it. Hemoglobin. Is their hemoglobin low? Is it under whatever number? Is it low? Is that why they're having a stroke? Because maybe they're not getting enough blood flow to the brain. Maybe it's because of low hemoglobin. Diagnostic procedures, we already talked about that. MRI is the one that we do want to look at.
Does it look good though?
Because it will show dead
Cranberry.
tissue. But the problem is that MRI is expensive and takes longer to do. CAT scan is easy. Get in there, check to see if it's a bleed, and start treatment. Usually the MRI is done afterwards. Depends on what hospital you work at. Sometimes if you come in the morning, it can be done that afternoon. But if you come in later in the afternoon, it's probably going to be done the next day. Because they don't want to come in. But MRA is the angiograph where they can go in, and it's kind of like a cardiac cath, but then they put that cardiac, they can go up and totally visualize the blood flow through the brain. Carotid ultrasound, they're going to look to see what's going on in those carotids. Is there bleeding or is there anything going on in those carotids? We talked about EKG. So here's our TPA. So why would TPA be contraindicated? I already told you one. Bleeding. How do we know they're bleeding? There's labs. Maybe they're bleeding, yes. Maybe their brain is already bleeding. I just thought of another contraindication I was going to ask you about. Major surgery. So, blood pressure? No, blood pressure is probably okay. But contraindications, what else? We looked at PT, PTT, INR. Why would those be elevated already? If they are. If they're already on anticoagulants. So some people that take aspirin daily, they're already ruled out. Think of all the elderly that take anticoagulants. They're not a candidate for, not even elderly, even like anyone with cardiac disease. If they take one aspirin a day, they are ruled out because they can't, because of the risk for bleeding. Recent surgery as well. Recent surgery within 3 months. A recent stroke within 3 months. They're not going to get TPA. If 1/2 or 1/3 their brain is affected, they're not going to get TPA. If they're over the age of 80, they're not going to get TPA. Their INR is above 1.7. That they're probably on Coumadin or something, and that's why they are ruled out. So these individuals will not get TPA because of this. So the way TPA works is you give 10% IV push. Maybe that's not true anymore. Or through the pump. It depends how savvy you are with your dosage cup, to be honest with you. But 10% of the body weight, you get your patient's weight, and then it's calculated, the dose is calculated, and whatever the dose is, you give 10% within a minute. So IV push within a minute, and then the rest of it, the 90% of it, is giving IV pump within the next hour. So remember with the lidocaine on simulation, in my groups at least, we talked about doing the lidocaine IV bolus, and then I would be with that lidocaine drip, following it right away. Same thing with the TPA. Whoever's doing, like, one nurse is doing an IV push of TPA, the other nurse that's dealing with the pump is like following in with the TPA. So it should be smooth movement. Like I said, whatever that time frame is, everybody knows what time it has to be administered, so everyone is on board getting everything done. So there's no delay in that medication. And I do have a video on how to mix it. The doses, the TPA is based on their body weight. 10%. So say their dose is, they're getting 75 milligrams. So 10% of that, 10% of that is 7.5, right? So then what's 90% of that? What's 90% of 75, or what's, put it this way, what's 75 minus 7.5? 7.5. So, see, this is stuff you gotta know on the spot. But that's why you have a team. Is like right now you're like, oh, I can't add and subtract that fast, but someone is gonna be able to do it. That's why you have a team of nurses in there, and PCTs and doctors. Everyone's in the room, and everyone's doing the calculations and making sure everything is correct. And you'll usually have 2 nurses starting IVs. Because if we get a third one in, oh, who cares? At least we got a third one in. But we have to have at least 2 IVs before we start TPA. And then before lunch, I'll show you the video on how to mix it. So the other critical thing is get them to a stroke center. Like, what's this plastic thing out in here? So once, some hospitals can take stroke patients, some hospitals can start it and then they move. Other hospitals can start the TPA, but their NIH stroke scale has got to be under 6 to keep that patient at the hospital. So there are certain criteria in certifications or accreditations for certain hospitals. But the biggest thing, start the TPA, get them to a stroke center. Once they are on TPA, you are doing vital signs every 15 minutes.
For 2 hours.
For 2 hours.
Then Q30.
Then Q30 for 6 hours, then every 1 hour for 24 hours. That's a lot of vital signs, right? That's busy work. So that's why that person is usually, it's 1 patient to 1 nurse. That's a lot of stuff going on with that patient. A lot of assessments, and then you're doing a neuro stroke scale, which you guys will practice that, and you're doing that every 15 minutes. Has anyone done that at clinical, a neuro stroke scale? I mean, it's pretty kind of time consuming, especially when you're first doing it, but we'll practice that too. So yeah, that's important, they're doing that every 15 minutes, because the sooner you see any kind of deficit, get worse or get better, then you can do a full evaluation. Because once that TPA starts getting in there, if it is working, you will see return of symptoms, like maybe they can speak again, maybe they can start moving their arm again, stuff like that. Keep the blood pressure below 180/105. That seems a little high for me, but it depends. So if you think about it this way, how is the blood gonna get to the brain to start to heal anything if we keep them hypotensive, right? So you still wanna have this elevated blood pressure to keep blood to get into the brain, because we still have to perfuse the brain. But if we keep their blood pressure low, then it's not perfusing the brain. And there are specific on the MAR on how low or where the blood pressure should be. It will be very specific, and usually it's 105, 180 over 105 that we want it. So if their blood pressure is 179 over 104, we're okay. Right now, I'm thinking, oh crap, but if there's specific guidelines, that's what we'll follow. No invasive tubing, we already talked about that. No IVs, no NGs, no Foley after the TPA is started. Stop the infusion for severe headache, severe hypertension, bleeding, nausea, vomiting. What is the worst headache of your life? And projectile vomiting. What's happening? Do we know? I haven't really talked about it yet. So the worst headache of my life, what'd you say? ICP, but what could be happening? They're on TPA. Hemorrhage. Now they're starting to have a hemorrhage. So there was brain bleeding, or maybe they had an aneurysm, and now that is ruptured. So usually those symptoms, aneurysms or head bleed, is their projectile vomiting, and they'll say the worst headache of their life. And they'll do multiple CTs, and they don't start antiplatelets like aspirin or anticoagulants until later, because just as you can imagine, the high risk. We need to know the cardiac death. What medication is important to know for stroke? So, okay, so this is what I was talking about. Maybe we're past the 4.5-hour window. This patient's 45-year-old, where they have a lot of deficits. What can we do for this patient? If we can't give them TPA, what else can we do? And some endovascular treatments they can do. They can fish a catheter all the way up into the brain tissue or into the brain vascular system and put TPA just at that clot. They can go in and actually retrieve the clot, but think about that high risk that they can do. These usually, let's see, they're over the age of 18. Stroke scale is above 6. It really takes a lot of evaluation and if they're going to do this, just because of the high risk of these interventions. Stenting, if there's just not a clot, but it's from plaque, they can go in and do a stent, just like we do with the heart. The problem is a complication with the ischemic stroke is with either clot removal or lysing or putting in a stent from plaque is this hyperperfusion syndrome. Is right now, say your brain is getting a lack of blood flow to a certain area. That area of tissue is now having ischemia or something. There's some cell death there. And then all of a sudden you open up that vessel and now they get blood flow. Are those vessels in that brain area going to be able to accommodate all that new blood? So that is what that hyperperfusion syndrome is. There's impaired autoregulation for the cerebral blood flow. So we're also looking for that. It's rare, but it is a complication. And then I talked about cranial bypasses where they can also with bypass, just like the heart, just like a cabbage, but a cabbage on the brain. But you're bypassing the blocked area and putting in new vessels to bypass the blockage. So what's important to know is how to manage these deficits. So patients who survive a stroke, if they have deficits, like I said, the brain will do what it wants. It could take up to a year. They say usually at a year is what they're going to be living with. And it seems crazy that it takes a whole year, but it does. So managing deficits, visually, they have visual impairment. Maybe they only have visual fields of half of their eye, half their visual field. So you want to teach them to scan, looking back and forth. We don't want them bumping into doors or tripping over things. Safety. So have them scan the area. Approach them from the unaffected side. So if you're the team lead and you're looking at rooms, which bed to put this patient in, make sure their visual field is at the door. Don't put them where their visual field is at the window because they can't see anybody coming in the door. So have them so they can be approached from their visual field. So you always want to approach from the visual field that they have. Place things in their visual, like I said, their medications, their trays, their food, whatever. Set them up. Place things in the same location, turn head side to side, like I said, scan the area, and then dressing the affected side first. I already told you about that. Sensory is, usually they might have temperature issues, so to have them check their hot water. Do they have temperature issues? Make sure they're aware of temperature extremes. Motor deficits, usually do range of motion, body alignment. One thing that I always see in rehab when I work there, around there, if someone's got like a right-sided stroke, but they have left-sided deficits, they're sitting in the wheelchair like that. So we need to sit them up straight, and they're not aware they're sitting like that. So usually we put them in a sling, put their arm in a sling, because we gotta protect the shoulder, right? We don't want it coming out of its socket. They don't have the muscle movement. You'll see them, because usually there's a tray on top of the wheelchair. You'll see them lifting their arm and putting it on the tray to protect that arm, or you could put them in a sling. Usually the order is if you get them out of bed, they can be out of bed with a sling. Support with a cane, splints, like they have stuff, maybe their ankles are a little weak, so you can get braces on their ankle. Allow time to respond because it will take some time to communicate with them. That's why it's so important to figure out how to communicate with patients that have had a stroke. They get frustrated, they can lie. Like when they're going through the NIH stroke scale, they know something's wrong. You're doing, say you're testing their cranial nerve 1. Can you smell this? I can smell it. It's like, really? Okay. You're lying to me. What do you smell? So they'll try to trick you. They do try to trick you, but you have to do it right, follow the rules, because we need to get an accurate assessment on these people, on these patients. There. Place food on the affected side. So when we give them their pills, because they can pocket areas, make sure we're looking at their mouth, making sure that they swallowed everything. Make sure they can swallow. So make sure that's why we do a swallow eval on patients that have had a stroke. Can they swallow? Are they at risk for aspiration? Verbal, what else did I miss? Did I miss something on there? Body alignment, I talked about that with the sling. Okay. Repeat the sounds, so verbal deficits, we'll get them with speech therapy. There's literally ABCs, start them with their words, with their ABCs, just getting them to learn how to speak clearly again. Simple sentences and simple choices. Don't give somebody don't expect them to say, okay, which shirt do you want to wear, and give them like 5 choices, one or 2 choices. Have them point to the one of what they want to wear to make it easier for them, because they usually can't comprehend that much, and too many choices could be overwhelming for them. Establishing communication. We have these communication boards or paper. They can point to what they're feeling. Cognitive deficits, we want to reorient them. Place familiar objects or family photos in their room. Favorite things. Use non-complicated language. We got to remember that we can't go go in with complicated language with patients. We gotta use terms that they will know. Match your visual with your verbal. That's why I can't wear masks anymore. COVID's out. So what I say, and they can see my eyes roll, but they can't see me not smiling. So match your visual cues with your verbal cues. Minimize distraction. Turn off the TVs. Don't have a lot of clutter in the room or a lot of things going at the same time. One person should be talking to them, like maybe it just kind of depends on what's happening. But only one person should be in there giving them directions. And especially afterwards, it's like, sometimes you're just like, okay, let's sit at the side of the bed. That's all you can tell them. And then it takes like 5 minutes for them to sit at the side of the bed, because in rehab, we have to wait that long. They have to do all the work themselves. That's why I'm not very good in rehab, because I wanna get in and get out of the room. Then it's like, once they sit up, okay, let's get you to the edge of the bed. Then it takes them a little bit longer to get to the edge. So simple, easy questions. Or commands.
They told me, like, at the hospital, like, when I worked there, they said to, like, open the blinds and, like, have light in the room during the day, because otherwise, like, it
That's a
can
good
cause-
point.
Yeah,
Yeah.
because they, like, if they don't have light or, like, can't, like, I don't know the word, but, like,
That's right.
the, like,
Just to
visual, yeah.
mix
'cause
their
it
day and
can
night
cause
schedule.
confusion, yeah.
So she said during the day, make sure you open up their blinds, they can see the light, so they know it's day, because that night-day does get mixed up. Okay, minimize distraction. Support patients and families, encourage group activities, provide a safe environment. I think you guys can get that. Complications, we wanna just really monitor for further deficits. Intracranial pressure, we'll talk more about that this afternoon, but anything that you can see that has swelling or extra fluid in the brain can cause intracranial pressure. So if you think about it, our brain can hold cerebrospinal fluid, blood, and brain tissue, right? So any increase in one of those, the other two have to compensate. And I know the signs and symptoms are, well, that's over there, but they're opposite of
Is
shock.
that what that is?
Oh, well.
I keep hearing like a vibration.
So
Is that?
opposite of shock, so they're gonna have high increased blood, what's
It just keeps vibrating.
that is, well, I probably broke it, or Abby broke it.
It was like moving along.
And it keeps moving.
It's like every now and then it kind of points up and then it like goes back in place and then it's
It vibrates.
As long as we don't.
I hope it doesn't do that on the test or something.
So monitoring for increased intracranial pressure, the symptoms for that is nice because they're opposite of shock. You're gonna have increased blood pressure, but low heart rate and respiratory rate. So opposite of shock. Interventions to reduce intracranial pressure are mannitol, that is the drug of choice, because it's an osmotic diuretic. It's gonna pull fluid from the brain area and get rid of it from the brain. Oxygen, we wanna keep oxygen above 95. There we go, our head of bed above 30 degrees again. Why do we care about the head of bed about elevated? Decrease pressure. It promotes it, because if your head of bed is up, it can help promote venous drainage from the brain. Keep that head midline, so it promotes that venous drainage. Blood pressure below 220 over 120. You're gonna be doing frequent neuro checks, monitor for fever, and you're gonna be checking blood sugars. Okay? Other complications are cerebral blood flow, so you might not have cerebral blood flow to the brain. That's why we gotta keep it elevated a little bit to make sure that the other brain tissue is getting perfused. UTI, why they throw UTI in there, I don't know, but your book does. Arrhythmias, So we're gonna be looking at that cardiac, your heart, see what that's doing, and immobility, because you are having problems, you're gonna be weak or you're gonna have paralysis. So you're gonna have complications, skin, contractures, any kind of skin problem. So managing the patient, I don't know what I meant. So how are we gonna manage an airway? What are we gonna do? Does that manage, what's the purpose of putting your head at bed 30 degrees? Decrease pressure in the brain. And another thing is we want their head midline, no extreme hip flexation either. We don't want them like cross-legged in the bed. We want everything so it can just flow out. But airway. Suction, if they need it. Yeah. Check gag reflex, yes, because not everybody is gonna be able to eat or swallow. Neurofunction versus vital signs, so make sure oxygen. And we always start with least invasive. We're not gonna just go throw in a face mask or intubate. Start with your nasal cannula and work your way up. Establish a baseline, your Glasgow Coma Scale. I don't know why that's on there. Electrolytes. Oh, I can put it in, never mind. Maintain fluid imbalances. Monitor for aspiration. Psychological support. Establish a means of communication. I can't stress that enough. Slow, deliberate speech. Like I said, sometimes I want to get in and out of the room, and rehab drives me nuts because I gotta say, just get to the side of the bed, and then I gotta wait. Or I want to help them do everything, and it's a different mindset. Does anyone work in rehab? No? So yeah, you know what I'm more of, let's get in, help them, take them to the bathroom, and get them out. Well, not in rehab. Slow, deliberate. You gotta have patience. I guess I don't have the patience. Range of motion exercises. Keep them moving those extremities, because even though they have deficits, they might have paralysis or weakness, we still want to move those arms and those legs. We still want to keep those, we don't want them to develop contractures in those extremities. Skin integrity, safety issues, so visual field, active bowel and bladder control. Sometimes it can cause incontinence or bowel problems, so we need to, usually with a neurological patient, we're starting about a schedule, like every 2 hours, get up, go to the bathroom, whether you have to or not, every 2 hours, get up and go. And we're helping them. Place some of these I've already said, PTOT, all right. So, you got it all. A nurse is admitting a client with an acute ischemic stroke. Which intervention is the highest priority for the client upon arrival to the emergency room? Continuous cardiac monitoring, obtain a CAT scan without contrast. B, assess the client's strength, maintain client in strict bed rest. Yep, I don't have the correct answers here, but you're right. It's B, not C. So we've got to figure out that cause of the stroke. Okay, yeah, I'll ask. Why do we do, I know you guys, why do we do CT without contrast?
If they're bleeding, right?
If they're bleeding, the contrast can, which is an irritant to the brain tissue and cause further neurological damage. All right, a client is in the ED with right-sided weakness, aphasia symptoms that began 45 minutes ago. CAT scan ruled out hemorrhage. Client meets all the criteria for thrombolytic therapy with alpha phase. Which of the following is a priority before administering it? Inserting the NG, performing bedside swallow screening, obtain a weight to calculate the dosage, inserting a urinary catheter to monitor output. That one's C. Because we can't start it unless we have the correct dosage. But all A, B, and C would be right if we have to do all those, but the most important one would be C. The nurse is evaluating the chart of a patient with TPA. Which lab value would be most concerning? A, because what does the INR need to, why is it contraindicated because of the INR? What does it have to be above?
Below 1.6, right? 0.9 to 1.2.
So when is TPA contraindicated? What INR?
Above 1.7.
Above 1.7. Because that means they're being anticoagulated with something. Coumadin, heparin, they're already being thinned out.
So, take away A. If they had
Okay.
B, C, and D, without A, would it also be contraindicated?
If we had B, wait, what's your question?
Patient has B, C, and D lab values.
Okay.
A, would it be contraindicated?
Would that be contraindicated? Why are the red blood cells high or low? Well, hemoglobin is low for hemoglobin.
It's hot.
It's high, so not really. White blood cell, what does that point to? Infection. Do we care if they have infection? No. Temp is 100.5. Is that our NFlex?
No.
101 is usually our NFlex. So yeah, they would be a candidate if you took away A. What if they were 81?
No.
No. What if they had abdominal surgery 2 months ago?
No.
No. Because we could just cause more bleeding, that wound could open back up. And the doctors would be happy about that. What else is contraindicated? What if they're on aspirin already?
No.
No. Plavix? No. Coumadin? No, none of those are.
If their blood glucose is high.
There's something about. So if they are, when someone is on Coumadin, like say they have blood clots, they're prone to blood clots, so they're gonna be put on Coumadin in that therapeutic range where their INR is between 2 and 3, right? You guys remember that? So, but one, they're already on Coumadin, so they're not a candidate, and two, their INR is between 2 and 3, so they wouldn't be a candidate either. This is a fun thing to do in clinical, and I'm hoping it comes down, I almost did it yesterday, was guess the INR. So if you come in front of a patient that's got a lot of bruises and a lot of skin openings, and we guess their INR. Isn't that a fun game? It's a sick game, but it's fun. But, I almost did it on,
I noticed that.
I know, yeah, I was gonna say, you know what, I almost did it when we walked in the room, I almost looked at you and said, guess his INR. I wonder what it was. All right,
Well, that takes
the nurse is monitoring a client with 12 hours with a large middle ischemic stroke. What Halloween assessment findings is the most concerning, suggest potentially fatal complication.
What did
Well,
you
we know
say?
it's
Halloween? Just say Halloween. Halloween assessment.
I'm not having a stroke. I kind of test you guys, see if you think I'm having a stroke. Which is probably a lot. All right, the nurse is, okay, 12 hours ago with a large middle cerebral artery ischemic stroke, which is the following assessment findings. Where would I have gotten Halloween in any of that? Is the most concerning and suggest fatal complications.
D.
Well, we all know it's D, but gaze preference toward the side of the stroke. So they're only looking at one side of their visual field, right? That's a little confusing. You're like, is that really what I'm thinking? A slight increase and the NIH stroke scale. It's slight, but do we have a baseline? We wanna know what maybe their baseline was 0 and now it's 1, we don't know. Always know a baseline, I think I've talked to you guys about this before. A sudden and sustained rise in systolic blood pressure, again, we don't have a baseline, maybe it was 100 over 80 and now it's 120 over 85.
Oh, so indeed, it shows you, it tells you that they had a baseline, because it says onset, like there was there before. Right?
So, unilateral, fixed, and dilated pupils. What's your normal? So our pupils should be accommodating. Remember Perla? You're doing that pen light, and they should be accommodating. But when they're fixed, that means they're pretty much dead. Not really, but that's the last person we see if there's a disaster. We put them off to the side because they probably won't survive. So unilateral, fixed, and dilated pupils are not normal. Perla is normal. If they have Perla, we're good. But if they don't, we check this. But no, all right. I have some more. The nurse is performing, neurological checks on a 48 hours after an ischemic stroke. Glasgow Coma Scale was 13. Your pupils were equal and reactive. Which of finding is most urgent? Might be 6 out of 10. 6 out of 10 is not bad. 9 out of 10, 10 out of 10, that means, and I have, that's usually pretty bad, but even that, 10 out of 10 pain, what's your priority? The Glasgow Coma Scale, because he went from a 13 to a 10. That's a pretty big drop. And so their level of consciousness went down. And well, I'll tell you guys. Okay. All right, so let's come back at 12:28.
12:28.
12:28.
Oh, thank God. Whew.